Now we're going to have Dr. Roger Dmochowski from Vanderbilt University in Tennessee, United States. And he's supposed to address to give some lights on use of native tissue meshes and even the robotic assisted surgery for prolapse. Roger?
Good afternoon. Thank you. Thank you to the organizing committee, Monsi, Paolo, Harry, for asking me to give this defense and reasoning for surgery for pelvic organ prolapse. These are my conflicts. I would like to say before I begin this speech that obviously there is too much data in surgery, and it's becoming confusing to both practitioners and to patients to present a coherent and accurate predictiveness for each unique individual patient. So much of what we have to tell patients relies on our own personal experience. And much of my lecture today will be philosophical rather than evidence-based, because the evidence exists. Unfortunately, in many circumstances, it is contrary and quite difficult to interpret because of the differences in study design, patient populations, and outcome results reporting. So where are we in surgery? We'd like to think that we've gone a linear path and developed the best operations and have succeeded where others before us have not succeeded. I think I would leave you today with nothing else, but this path has not been straight. It's certainly been curvilinear at best, and in some cases completely circuitous. And we have left ourselves with difficulties related to the adoption of new technologies and also our own personal professional assessments of our outcomes. And the plea that I would have for all of you who plan or do active surgical intervention for patients is do what you are best at and what your technology you are most familiar with. The use and the abuse of new technologies has truly damaged many women with pelvic organ prolapse worldwide. And I think from a professional standpoint, my plea to all the surgeons in this audience would be that we are circumspect in our evaluation and honest with both ourselves and our patients as we adopt new procedures and new techniques and new interventions. So my first point is the presence of prolapse does not need necessarily intervention, certainly not surgical intervention. And often women are referred for surgical evaluation who've been told by a practitioner, as Ron has said, that they have the presence of a prolapse but are absolutely asymptomatic. In my view, it's not the best thing for the patient to operate for asymptomatic prolapse, and my certain teaching for my trainees is not to intervene for that patient. We have been a slave in the past to anatomic correction as being the holy grail of prolapse correction. Unfortunately, anatomy is only one part of the correction of prolapse. It's also the individual bearer of the prolapse that we must consider. And as Rene said, prolapse is just not an anatomic problem. Functionality of the patient is critical, and the recognition, unfortunately, very recently, that functionality is multidimensional has really affected our surgical outcomes reporting. So we know that there are multiple domains of functionality. Renee mentioned these previously. I think it's good to underscore them because every woman has a bit of a different presentation, and this is so important as we move forward to the potential of a quote-unquote permanent intervention such as surgery. So we must consider and discuss the relative presence or absence of urinary symptoms, gastrointestinal symptoms, sexual dysfunction, and also those individuals who have somatic sensory discomfort and pain associated with their prolapse. All of these are different forms of the presentation and impact the individual's expectations. And again, one of the most important aspects in my mind of surgical intervention is the appropriate preparation of the patient prior to surgical intervention so that you as a surgeon can actually tell the patient the reality and probability that her most bothersome symptoms may be obviated by the surgery or corrected by the surgery, but also that she may be taking a risk. And that risk is she may develop new functional disorder, which may be very problematic for her. For me, I consider surgery only in what I would call the index patient. High-grade compartment or apical prolapse greater than stage 2 with or without associated anterior and posterior compartment defects. For me, the patient must be symptomatic, and she is desirous of surgical therapy. And desirous of surgical therapy includes an exposure to non-operative and minimally invasive options such as physiotherapy and pelvic pessary management prior to surgical intervention. The goals of intervention clearly must be delineated with the individual. We must aim for improvement in function, not only her prolapse symptoms, but also the associated functional concerns that I mentioned to you previously. Yes, we'd like to have restoration of pelvic support. However, as has been shown clearly in the literature, you can have patients who've had anatomic failure who are quite symptomatically happy after intervention. So anatomy is a secondary outcome, nonetheless one that we must keep in mind. And then, of course, as with all things related to pelvic dysfunction, the benefit of the procedure is in the eye of the beholder, the eye of the bearer of the prolapse. We are not successful if the patient doesn't think us successful. We have a variety of surgical approaches to consider. We'll have a brief discussion regarding open vaginal versus abdominal. We'll also discuss the quote-unquote minimally invasive procedures, laparoscopic versus robotic. I think some factors that influence approach are critical, and this is really, again, dependent upon the individual practitioner and that surgeon's experience with various approaches. Certainly the anatomy of the prolapse may dictate the type of intervention we choose. The patient and surgeon choice. Certainly, some individuals do not want an abdominal incision. Prior interventions can clearly influence a prolapse surgical approach, specifically those prior interventions that have narrowed the vaginal introitus and make a vaginal approach very difficult, patient age, and comorbidities. And again, the expectations of the individual have a great deal to do with that choice of final prolapse procedure. And the best example of this is the vaginal obliterative procedure, such as colpoclesis. Wonderful procedures, but certainly not for sexually functional women, and those that should be reserved only for women who have no concept of proceeding with sexual function at all in the future and are willing to lose that aspect of their humanality. So we have a variety of native tissue repairs that can be considered, and it's a literal laundry list, if you will, of choices. Why is this? Well, because there is no one universally successful approach, unfortunately, for the management of prolapse. So we have a variety of anterior, apical, and posterior prolapse procedures to be considered. As you know, we are in the midst of a great debate regarding native versus synthetic and other types of interpositional graft repairs. I'm going to confine my native repairs comments only to the posterior approaches, that being the site-specific and the standard rectoceal repair, because the remainder of my discussion will be regarding mesh and robotics for anterior and apical prolapse. And I think the prolapse repairs done posteriorly exemplify the complications that we all have with surgery related to surgical choice and surgical experience. As you can see, as we describe these procedures, we have a lot of aspects to these procedures in terms of correct technical performance of these procedures that are very much dependent upon individual surgical experience. You can read these in the textbooks, but it is the individual surgical experience and that surgeon's length of experience that very much impact these results. So, for instance, with the site-specific repair, we have these codicils regarding 3-finger breadth, avoid over-narrowing of the vaginal hiatus, perineophraphy, as indicated. Clearly, a lot of surgical decision-making at the time of the surgery, the art, if you will, of prolapse surgery. Similarly, with standard posterior repairs, we see anatomic cure rates approaching 76 to 96% with follow-up of 12 to 42 months, with or without levator plication. And again, levator plication is a very standard type of plication repair, but one that may have a higher incidence of dyspareunia and sexual dysfunction. With site-specific repairs, success rates have been reported to be as high as 100%. But again, the famous problem with surgical outcomes is lack of durability or length of those particular outcomes. I'd like to spend a few moments with transvaginal mesh procedures and then robotics because, again, these demonstrate the problems with technical integration into practice and where we as physicians and surgeons should do a better job of policing ourselves and professionalism related to surgical repairs. So the principles of transvaginal mesh obviously have been written about extensively. It's tension-free mesh placement, no trimming of the vagina, adequate depth of dissection, and again, mesh has been described for all 3 compartments of the vagina, usually utilizing some form of total mesh insertion with or without support by cannula use. There are certainly now meshes that are being emplaced only with sutures or even without even suture fixation for the purpose of trying not to get the phenomenon of auto-tensioning of the mesh, which can occur at the time of surgical implantation. And certainly as we look historically, there's been a great deal of data presented. This is a typical surgical results paper looking at 120 women who underwent either anterior and or posterior repair. And as you can see, the gold standard in this paper was free of recurrent prolapse. They do report erosions in this paper, but what's missing in this paper, as in so many of the earlier surgical reports, is functionality. How was the individual's functionality improved, unchanged, or even worsened with new functionality problems developed by the surgical repair? We have seen the development and further elaboration of results reporting related to the various complications related to mesh, including extrusion, sexual dysfunction, and vaginal erosion, all of which have been noted to be increasing, and also seem to be co-located to certain surgeons and certain procedural types. Certainly in North America, we've seen, unfortunately, an epidemic of mesh-related complications, relatively uncomplicated, simple mesh erosions that can be managed usually only with local excision of the mesh, to what I would consider very, very dramatic complications such as intravesical and intraurethral erosion, which can be quite problematic to the individual from the standpoint of her symptoms and functionality. Is this a mesh problem, a technical problem, or a surgical problem? It's probably a combination of all three, but certainly we have to be asking ourselves as surgeons, are we technically competent to be putting these meshes in? We know that with the Cochrane database, the use of synthetic mesh has been shown to give very good one-year anatomic outcome results, and that the overall results for this should be weighed against the rate of mesh-related complications. And again, this was the conclusion of the first Cochrane analysis looking at the specific use of synthetic mesh outcomes. But there have been arguments against the use of mesh. The improvement, for instance, in anatomical outcomes does not equate to overall functional benefit. And there are many surgeons who feel that the primary use of mesh is not worth the exposure of mesh complications to the general population, and that serious complications, especially to the urinary tract, as you've seen, can be devastating. In the United States, the Food and Drug Administration, the government, has become involved in this discussion from a standpoint of regulation, and the government was quite decisive in its decisions regarding mesh. As you can see, there is an anatomic benefit in their conclusion, but no proven clinical benefit, therefore no benefit to the use, especially primary use, of synthetic mesh for pelvic organ prolapse repair. They actually, this brought about federal or governmental mandates, and it's specifically requiring all companies to do modified trials to better assess all of these devices, and also all the devices were increased in their severity level to a class 3, which means a device that can cause significant complication, as we've seen. But what they also point out was the need for process improvement. And this is where we have a significant onus placed upon us as surgeons and physicians. We previously had no defined surgical skills requirements for the use of mesh. We had no surgical skills objectives and training programs. We had no defined surgical competency requirements, which were critical. These content requirements also did not include proficiency assessments, and there was no substantive discussion of potential complications. These are all areas where we failed. We as surgeons have failed to our patients, and this is one of the critical areas of concern regarding mesh. I'm not completely against mesh, but it is something that it is a discussion which every patient must be aware of. And if you are contemplating an interposition graft at the time of prolapse repair, which may be a reasonable solution for some patients, certainly she should be aware of the risk and associated complications. And we need to do a better job of training ourselves when we have new technologies develop. The apex of the vagina is the Achilles heel of vaginal repairs, and certainly vaginal apical repairs are legion, but the best obviously is abdominal sacral colpopexy, and in my mind, the open sacral colpopexy still represents the gold standard for surgical outcomes in terms of prolapse if we are considering the surgical patient. Well, recently, sacral colpopexy discussions have been complicated by, again, technology. Laparoscopic colpopexy and also robotic colpopexy have become increasingly reported. What's become clear, though, with both of those techniques is that there is a learning curve. And this is a very interesting study that was published several years ago from the Mayo Clinic looking at the development of robotic learning curves. And as you can see, what this study showed with greater exposure to cases and operations, the mean operative time decreased, as did complications. Again, implying that a new technology does have a learning curve associated with this. And I think this is also true of our mesh experience. The evidence analysis also shows that when we look at laparoscopic, and you can read robotic for this slide, that the overall results are very good. This is, again, a meta-analysis that was published looking at greater than 1,000 patients in 11 series. And as you can see, the overall satisfaction rate, whatever that means, because, again, it's individually defined for the papers, was approximating 95%. But there were reoperation rates and mesh erosion rates. So even though the laparoscopic sacral colpopexy was, in their conclusion, the gold standard version of abdominal sacral colpopexy, it still had a relative non-perfection in outcomes reporting. One other important consequence of these new technologies as we move forward in Western society and really throughout the world is expense and cost. And this was a very nice paper done comparing open laparoscopic and robotic-assisted sacral colpopexy. And clearly there was an increase in cost from open to robotic procedures with no real benefit for the advanced procedures in terms of overall patient benefit. Very important discussions that we must have with both our patients and now with our governmental authorities as we ponder the use of new technology. So this is my paradigm for the evaluation and surgical management of prolapse. But again, before we go through apical and then descend through the various types and ages of the patients, I think we must consider that the patient is appropriately informed and it has at least been considered for non-interventive or pessary management therapy prior to going to surgical therapy. So in my practice, surgical therapy is the last choice for an appropriately informed patient, but still a very good choice for the appropriately motivated patient who is well informed. So I'll conclude by saying that we have reasonable technologies, not perfect for the management of surgical management of prolapse. There is definitely a learning curve, especially with the new advanced technologies. But let's be honest, even with standard plication and native tissue repairs, there's learning curves. We need to have a continued critical evaluation of our outcomes. And most importantly, those outcomes must be linked with the woman's expectations. Because if we fail that, we really fail ourselves and the patient. Thank you very much.